cancer, et cetera. And we're completely rethinking. There were roughly around 300 fewer treatment options back then than there are today, and that number is increasing dramatically. It's actually an exponential increase, and I would say that probably over the next couple of years, it'll be over 500-600. There were only 3 basic treatment modalities. There was just surgery, radiation, chemotherapy. We were starting to do immunotherapy, a little bit of bone marrow transplants, et cetera. But now those are like established, and immunotherapies have really taken a hold of the cancer community. What that is basically biologic therapies, targeted therapies that are focusing on cancer, but not the healthy tissues, reprogramming the immune system in ways that can fight the cancer. These are things that we couldn't think of 30 years ago, and now we're at the forefront of doing that. And then supportive care. Getting patients through their cancer treatment was very different 30 years ago than it is today, whether it's nausea control, whether it's pain control, whether it's neuropathy, and all the other things as well too. So we're living in a different world right now. And that is really a remarkable thing to be a part of. We could look at progress through many different ways over the last 30 years. We could look at progress in terms of treatment. So we measure the number of new therapies. We know that we have much more advanced imaging and early diagnostic strategies. We think about precision medicine, where you're understanding the genetics of the cancer, and according to the genetics of the cancer, you can tailor your therapies. And immunotherapies have, like I said, have revolutionized our treatment of cancer. How do you reprogram the person's own immune system to then fight the cancer instead of giving more toxic therapies? Another way we can think about progress is prevention. So we've gotten really, really good at preventive strategies. We are doing much better at treating of infection-related cancers like HPV-related cervical cancer and vaccination around it. Cancer susceptibility genes are being identified every single day. So you can identify genetic predisposition for cancers and early detection. And then we're doing a much better job of tailoring the chemotherapy, the radiation, surgery in much more precise ways than 30 years ago. So those are really sort of all preventive approaches. We're starting to recognize the importance of quality of life. It's not just get somebody through the cancer treatment, doesn't matter what the costs are. We want to make sure that we can maintain some level of quality, not just during the cancer treatment, but during survivorship. Ultimately, it's about maintaining dignity and a sense of purpose that many people want to preserve. We are doing much better at managing the toxicities associated with the cancer treatment. When possible, we are de-escalating the treatment. So instead of increasing the intensity, we're pulling back from cancers that have very good survival rates. And then for end of life and other palliative care strategies, we're doing a much better job of integrating that into our care. And then finally, the field of survivorship, as I mentioned, it's exploding. Cancer survivors are now becoming a growing population. And we're getting much better at understanding and speaking to cancer survivors, understanding what the journey is and how unique that is and how to address the unique challenges of survivors. If I were to summarize everything I talked about in one colorful slide, it's that during the past 2 to 3 decades, cancer mortality here has gone down, and cancer survivorship, by definition, has increased. So this is basically the number of cancer survivors in millions. And in 2020 alone, there were about 18 million. And that's somewhere around 20 to 22 million today. And it will continue to increase exponentially. So survival is improving. The number of survivors are increasing. And the other thing I'll bring to your attention are the colored bars. This basically is showing how many years someone has survived after their cancer diagnosis. And what you're seeing is that this is 15 years, this is 10 to 15 years, this is 5 to 10 years. So what you can see is the majority of these cancer survivors are living more than 5 years after the death. So the long-term survival is an expected outcome. One of the things that we came to recognize in the survivorship journey is that the cancer treatments themselves, chemo, radiation, even immunotherapy, surgery, can have long-term side effects many of the debilitating side effects survivors will have to face for years. In the past, once your cancer treatment ended, that's when the umbilical cord was cut. You were like, great, go on, live your life the best that you can. But now we understand that there's a lifelong journey that needs to be anticipated for these individuals, that these side effects, not while side effects like nausea and hair loss and other things are more temporary associated with the treatment, there are longer term issues that need to be addressed. And these are often underappreciated in the general practitioner community. So in a family practice, for example, where it could be a handful of cancer survivors, not necessarily thousands or hundreds. So there isn't that awareness about the uniqueness of this population. Why do we care? It's important that if we know that certain treatments can cause long-term side effects of X, Y, and Z, we could be much more proactive and identify these problems earlier in the cancer community. And that's really, really what the heart of what we're going to talk about. And I'll give you an example of why, as a pediatric oncologist, I decided to focus my research and my work in survivorship, not just in pediatric, but adults as well, too. So there was a 17-year-old that I saw while I was at Children's LA. During my training, she had stage 4 Hodgkin lymphoma. She received very aggressive forms of IV chemotherapy, as well as radiation therapy. And she had stage 4 disease. And she had a lot of toxicities associated with the treatment. But we got her through it. In 6 months, she was in remission, was doing well. She had got into University of Michigan and wanted to go Midwest to essentially start college after high school graduation. She was a star athlete, soccer player. She went and she was playing, and all of a sudden, over the next year or two, started complaining of respiratory symptoms, difficulty kind of being more fatigued and having some swelling of the hands and feet. Went to urgent care. They gave her antibiotics, etc. They said, you're just, you're not sleeping well. Long story short, run around until when she eventually came home for Christmas time. And the parents called me and they said, well, there's something off. She's saying that she's fatigued, she's sleeping all the time. And I said, well, why don't you bring her in and let's get an x-ray. And so then this was her x-ray before, right after her cancer treatment was done. So this is a completely normal x-ray. What you're seeing here is essentially, that's the heart in the middle. These are the lines of the ribs. The black is air because that's your lungs. So the more dense something is, the more white you see something. This is the diaphragm, this is the liver, this is the spleen, completely normal chest x-ray. Okay, this is what it was after she was done with her cancer treatment. When I saw her in clinic, I examined her. I found some findings that were concerning, and this is what her x-ray looked like when I saw her on her follow-up visit. And this is, she had been having all those respiratory symptoms and stuff. And what do you see here? You essentially see that her heart had ballooned to twice the size of what it should be. And her lungs, instead of being full of air, black, were fluffy, full of white stuff, which was fluid that had accumulated. So she, at the age of, I don't know, at the time she was 18, 19, had developed congestive heart failure, which is basically where your heart doesn't pump. Your heart's a muscle. Heart muscle gets so weak that it's not pumping well enough. And that's something that we don't see in the general community for individuals until they're in their 70s, 80s, and beyond. So it was missed by the general doctors that were seeing her because they forgot to ask her if she was a cancer survivor. And she's a teenager and young adult. They didn't want to reveal that she had that diagnosis. So it was missed. And this is a direct result of some of the chemotherapy that she received for the cure of her cancer. So not everybody develops this. It's a relatively rare occurrence, but it can happen. And the survivorship journey has to be accompanied by providers who are aware of what the unique risks are for this population. Had she not come in to see me, this probably would have been sort of moved at a much faster rate. And I don't even know if she would have been with us. She ultimately had to have a heart transplant to get for management of these symptoms, but she's doing well. She's married, living her best life possible. So I think it's important for us to understand that the journey doesn't end when the treatment ends, that we have to be aware of the uniqueness and the specialness of the cancer survivor population. So what I'm going to do today is I'll focus on sort of at the high level, some of the general things we think of in the cancer survivorship community that we should be vigilant and aware of. That by no means this is like an exhaustive list of every single thing that can happen to somebody. But I just want to give you a flavor of what we're thinking about and how we can actually be much more proactive. So I told you about heart disease, which is what my patient ended up having. She had this thing called cardiac dysfunction, where this is a cross section of the heart where you're looking at the heart directly straight up as a slice. And what we saw is that the heart muscle itself had weakened. So this is essentially supposed to pump, and the pumping ability of the heart was not working. And so she had developed heart failure. There are other patients who develop cardiac arrhythmia. So the rhythm of the heart doesn't work as well, or the conduction doesn't work as well, the electrical current across the heart, and that can cause some major issues. Patients will develop hypertension associated with due to blood vessel problems, as well as kidneys, as well as early onset atherosclerosis. Typically, these are associated with radiation exposure. So anybody that gets radiation near the heart, we worry about cardiovascular issues in that area. And this is typically associated with certain forms of chemotherapy, as I mentioned. So what do? Well, it's important for certain patients, not everybody, to have risk-based surveillance based on the treatments that they receive. So if you receive this high-dose chemotherapy that can cause heart failure, it's important that they are actively engaged with not just a comprehensive history and physical. When I'm examining my patient, I'm thinking, okay, what medicines did they receive? What are the things I'm looking for? But we also do imaging. We do echocardiography, where ultrasound of the heart regularly every 2 years, every 5 years, depending on where their risk is. To look for heart function. How is the heart pumping? Because we want to catch a problem before they become symptomatic. But it's just as important to understand that there are a lot of other modifiable risk factors. So things like hypertension, diabetes, high cholesterol issues that develop later in life that become the second or third hit that these patients will have, these survivors will have. So the first hit, for example, is the chemotherapy, right? That can cause some form of injury to the healthy tissues. But when you add to that aging-related problems like high blood pressure, diabetes, cholesterol, it kind of makes the situation a little bit worse. It makes my job a little bit, I can't take away the fact that they got the chemo. They had to get the chemo to be cured. But what I can do is I can be much more aggressive in how I manage the blood pressure, blood sugars, and the blood cholesterol levels as well too. So that's all within my control, and obviously within the patient's control in terms of compliance and everything else as well too. The key is to prevent. We tell our patients, heart healthy lifestyle is incredibly important. Cutting down on salt, cutting down on cholesterol-rich foods. Heart healthy diet is really key. Of course, never smoke, but if you are, then stop. Physical activity, which I'll talk about in a minute, is very, very important. And appropriate compliance. There's no use in me prescribing medications to control your blood pressure or tell you how to control your blood pressure and your cholesterol and diet through a heart healthy lifestyle if there's no compliance on the other end. So it's a true partnership. So I talk about exercise because people ask me about the role of exercise. If I were to answer one thing, is to essentially tell you is the more you exercise, the better your overall likelihood of not developing cardiovascular disease. So this was a study that was done that looked at the intensity of exercise in cancer survivors and relative risk of developing heart disease. And what this is patients who did not exercise at all, basically 0 metabolic minutes per hour, hours per week. So basically this is just, not exercising at all. And then this is based on the CDC guidelines. The more intensive the exercise is, and I'll tell you what the formula that we use. And this is the risk of developing heart disease. So what you see is these folks, the more you exercise, the lower the risk of heart disease compared to someone who doesn't exercise. Okay, it's kind of intuitive, but what we show here is that exercise is good for all cancers. And now, when you look at the typical CDC recommendations, so if which is 9 mets per hour per week, which I'll show you what that means, you can cut your heart disease risk by half. So you can't change the fact that you receive certain chemotherapies and radiation and other things, but you can adopt a healthier lifestyle. So what we tell all of our survivors is aim to do at least 150 minutes of moderate aerobic exercise, like walking every week, or resistance exercise at least 2 to 3 times a week. So integrating any level of physical activity is going to be good, but the CDC recommendations of 150 is really what you're going to go for. So, 50 minutes 3 times a week or 30 minutes 5 times a week is really, that's all you really need to cut your heart disease risk based on this data by. Now I will talk to other areas that we focus on as well too, because I take care of a lot of adolescents, I take care of young adults. One of the biggest concerns they have is this chemotherapy, is the radiation, is the immunotherapy going to impact my ability to have kids and get old as I get older? I'll talk briefly about some of these issues. So for males, the biggest barrier to having kids or fertility, to preserving fertility, is chemotherapy. And then in some cases, we have to give radiation to the testes. Obviously, that impacts their ability to have children. Males are much more sensitive than females. Females typically can have certain forms of chemotherapy and not have it impact their eggs, but high doses of chemo definitely will impact health and egg function. And then women who receive radiation to the abdomen or pelvis, obviously that can impact reproductive health as well too. So for males, if they're pre-pubertal, which I won't talk about too much today, but if they're post-pubertal, it's pretty straightforward. Any male patient that comes in who wants to have children down the line or has anticipated to have children, we do sperm banking, and it's pretty straightforward. We have resources in which we can help them bank, and then we've had dozens, if not hundreds, of patients in our survivorship program who have been able to go back and thaw sperm and have kids down the line. Females, it's a little bit trickier. So as I mentioned, it's tougher so female eggs, oocytes, are much more resistant to chemo, but high doses of chemo can impact egg health as well too. So females, unlike males, are born with a limited number of eggs, and those essentially decline. This is the normal, let's say, the biologic health of women. The number of eggs will decline until you get to about 25,000 eggs, and that's sort of perimenopause. And then once you go below 1,000 eggs in the menstrual cycle, obviously you're shedding more, you get to menopause. So this is sort of the normal female trajectory of reproductive aging. What happens in our cancer patients, sometimes, not thankfully rarely, sometimes you will have a rapid depletion of all the eggs. So all eggs are wiped out because of the chemotherapy or the radiation that they receive, and they enter menopause decades earlier than typically would be especially if they're an adolescent. More often than not, this is what we see. We see kind of it takes a hit, but then the trajectory changes so that perimenopause starts around 20s, and then menopause will be in sort of in the 30s as opposed to in their 50s. So there's this concept of accelerated aging that we're seeing in some of our patients, and this is one of those manifestations. So it's important for us to be able to track this, and there are blood tests that we can track this. The reason why it's important is because if I have someone who's here and they're on this trajectory over here, I will refer them for egg harvesting and banking, even if they don't have a partner or someone that they're willing or they're ready to have a family with, because I look at this as a window of an insurance policy. Now, this is costly, but thankfully insurances are now more and more covering this. And at City of Hope, we've established mechanisms where we can actually subsidize some of these efforts as well too. It's important when we talk to our patients that just because they're infertile doesn't mean that they actually have symptoms. So some people will say, "Oh, she's still having her periods." That doesn't mean that her reproductive health is 100%. So it's important for us to do certain tests and biomarkers to look for that. We always tell our patients, just because you lost your ability to have kids doesn't mean that prevents you from these random situations of unwanted pregnancies. I've had situations where we do the sperm analysis on a patient and we see that there's actually barely anything there, and then all of a sudden they come in the next year and there's a little baby there. And more often than not, they've done DNA testing and it is the actual father. And so I tell them, just because this is the lab test doesn't mean that this is the all end all. So if you're not ready to have kids, make sure you're protecting yourself, not the least of it, because there are always a risk of STDs. Chemotherapy will not take care of STDs. So the one question I get asked from a lot of young adults and young patients is that, if I got chemotherapy or I received radiation, et cetera, does it impact my ability to have kids later on in terms of helping kids without any genetic mutation? We have no data to suggest that the chemotherapy itself will impact someone's eggs or sperm in a way that you would pass on any negative to your offspring. There are genetic conditions that potentially put you at risk for getting the cancer at first that you may pass it down, but it's not the chemo or the radiation, if that makes sense. We follow patients. We follow patients over time. The high-risk patients we follow for females, we follow hormone levels, FSH, LH, AMH, which is another measure of egg reserve. It's like how many eggs do you have left? It's a surrogate marker of that. Like I said, just because you're menstruating doesn't mean you have full reproductive health. For patients who are a bit older, they start having symptoms of perimenopause or menopause, then obviously hormone replacement is key for many, many different reasons, besides sexual function and libido, but also for bone density as well too. And then we work hand in hand with our endocrinology colleagues to make sure that we're optimizing their health for these individuals. Another area that we are seeing increasing attention paid to is bone health. So, there are many reasons why patients will have an advance or weakening of their bones with their cancer treatment. So the cancer experience itself is what we call a high inflammation type state. Your body is fighting. Your body's fighting aggressively against the cancer. When you have a lot of inflammation in your body, that could definitely impact your bone health. But specifically certain chemotherapy or drugs that we use to control the cancer, sometimes to control the nausea, like steroids, can weaken your bones over time. So it's important for certain cancers where patients are on steroids for a long period of time, certain leukemias, certain lymphomas, it's important to monitor bone health. Prolonged bed rest, that's one of the best ways to get osteoporosis is stay in bed, So, astronauts, when they go up to space, they now exercise them, they put them on treadmills, they make them do all these things. Why are they doing it? Because weightlessness, exactly, weightlessness is one of the biggest sort of culprits for bone loss, and bed rest is like weightlessness. So it's important to replace hormones that are necessary, vitamin D, calcium, and then we also can monitor this. We do bone density scans like DEXA scans, which is like sort of a fancy way of looking at bone and muscle composition of the body. We can look at a CT scan, look at bone strength through there, measure vitamin D levels, calcium levels, and then optimize. And we not only have to make sure that the vitamin D and calcium levels are optimized in these individuals, but if there's true osteoporosis, then they may need to be on certain medications to help bone resorption and bone health as well too. So this is something that's really done hand in hand with an endocrinologist. And not everybody's going to have bone issues. I'm just saying like these are some of the high level things that we see commonly. Best way a patient can prevent this comes back to physical activity. You'll see me saying this. So in fact, the way bones get strong, believe it or not, it's counterintuitive, but they get strong through impact. So any kind of aerobic exercise where there's actually weight bearing and you're actually sort of challenging your bones, obviously assuming it's safe to do, assuming you're not going to get liver completely. But that's going to be key. Obviously, smoking is one of the bigger culprits for osteoporosis. Alcohol intake, you have to limit that, and then moderate light exposure, I say, because obviously vitamin D, one of the main sources of sun, but you also don't want to get to the point where in order to prevent osteoporosis, you're getting skin cancer. So you just have to kind of moderate it. Okay. So, one of the highest population of individuals who are at risk for cancer or another form of cancer are cancer survivors. That's many, many reasons why. Some of it is that they have a genetic predisposition for whatever was the reason why they developed the cancer in the first place that put them at risk for getting another type of cancer later on. Some of it is related to the chemotherapy that they receive. Some of it is related to the radiation that they receive. So there are many different reasons. So it's important for us in the survivorship community. Again, not everybody's going to develop a different type of cancer. But if you have received radiation, for example, to your chest area, so some of the lymphoma patients, female lymphoma patients, because a lot of lymphoma is going to be in the chest mediastinal area. We always have to watch them for risk of developing breast cancer because there can be scattered radiation to healthy tissues. So for those individuals, we do early mammographies, we'll do MRIs in their 20s and their 30s, kind of like those in the general community, like the BRCA1, like the Angelina Jolies of this world. We're much more aggressive in screening and preventing. For patients who receive radiation to their head and neck area, we're following their thyroid, making sure that there's no, because one of the areas that gets radiated is your thyroid. Your thyroid is very susceptible to radiation. So we want to make sure they don't develop thyroid-related thyroid cancers. And so we're always examining and also doing ultrasounds for any concerns. Certain chemotherapy drugs can cause leukemias within 2 to 5 years of completing the treatment. So for them, we monitor blood counts and look at white blood cell count, red blood cell count, platelet count. If we start seeing worrisome trends, then we'll do additional investigations. So these are all examples, nothing for you all to remember, except just to know that there are people out there in the community, especially at City of Hope, where we are actively following and monitoring, doing risk-based surveillance for these issues, so that ultimately we can do early interventions before things get out of control. So what can survivors do? Well, for those who are at risk for breast cancer because they receive radiation to their chest areas, we tell them that you need to be much more vigilant, do self-examinations monthly. We show them how to do it. And stop smoking again, limit alcohol intake again, and then comply with screening recommendations. So patients who at a young age receive abdominal radiation, they're at risk for developing colon cancer later on. So for those individuals, we recommend colonoscopies earlier than what you would get for the general population. So that's our recommendation. If the person isn't going to go and follow through with that recommendation, we can't grab their hand and physically take them to the colonoscopy suite. We can't take someone who's received chest radiation to the mammography suite. So it's a partnership. And you all, many of you in this room are such active, engaged individuals, but you'd be surprised how many people are just not, and it makes sense. Some people just want to experience behind them, or we're too young to fully understand the long-term consequences of this. Last few slides, I'll talk about some of the not organ-specific issues, but the more broader issues. We're talking about one of the biggest things that comes up is, I went through this journey but my quality of life is not the same as it was before my cancer journey. But that's such a broad term because there are so many different aspects of what constitutes a good quality of life. It has to be a combination of physical well-being, psychological well-being, it's spiritual well-being, social well-being. So it's a combination, and all of these get disrupted during the cancer treatment. And all of them have a variable latency of when they actually come back to normal, if ever. And that fundamentally shapes the quality and the quantity of life ultimately that many of our patients have. This is one of the most common or more frequent subjective complaints that we hear, long-term survivors. Issues related to fatigue or depression, musculoskeletal complaints, aches and pains, and difficulties with concentration, forgetfulness. These are all normal, and they happen at varying intensities based on the person, who they were before they got the cancer diagnosis, the cancer treatment, as well as the post-cancer complications that develop as well too. The less frequently mentioned, but just as important, are issues related to sexuality, body image, financial hardship, co-pays, and all the lingering issues of financial toxicity that we're starting to understand are so important to address in a regular clinic. And then for our young people, social reintegration. I have so many patients that I take care of who are in their late teens, early 20s, that you pluck them away from college, you pluck them away from high school, you pluck them away from whatever job that they were in, and then the cancer treatment is done. And during that period of time that they were plucked away, they're isolated, they're removed from their peers. And then you say, okay, go back and reintegrate into all of that. And it becomes a journey. It becomes much longer than the cancer treatment itself in terms of finding that right balance, the right support network. And even don't have spouses or other life partners that can help them navigate. So we're very mindful of those challenges. So speaking of the cancer fatigue, that's an area that we hear about quite often. And that's the most challenging one that I tell you that I face trying to untangle for our cancer survivors. Because when we think about cancer fatigue, it depends on when it is. Is it during the cancer treatment? Is it shortly after? Or is it long term? But regardless, you can see how all the different things that could contribute to cancer-related fatigue. So you need someone who understands the cancer treatment, and is asking the right questions. Is it the fact that you're not getting the best sleep possible because your sleep has been persistently interrupted even after your cancer treatment is done? Is it pain? Is it the fact that you're anemic? Are there hormone imbalances? Are you nutritionally optimized? Or is it medication side effects that you're currently taking? So someone, one of the key issues is to make sure that someone looking at you through the lens that you need to be looked at, as opposed to a one that's for the general population. So, what are my sort of general broader pearls? What I always tell, how do you sort of take charge and try to tackle some of the quality of life issues after cancer treatment? Well, you're a pretty engaged audience, but I would say that you'd be surprised how many people are not engaged. I'll ask them, when is the last time you saw your general doctor? And they'll be like, well, I haven't seen him. You're my doctor. I'm like, no, I'm an oncologist. I'm a survivorship doctor, but there are other issues that need to be addressed that you need to be engaged. Recognize your emotions. There are varying emotions across the journey related to guilt, confusion, anger. But that said, for many of our patients, I look at this as a new perspective on health, a second beginning, an opportunity to really take charge, because so much of the cancer journey itself, you had no control over it. I always tell patients, reduce stress through small changes in your life. We're so wanting to say yes and be compliant and be good patients. It's okay to say no. It's okay to be selfish. It's okay to say, no, I need to focus on myself. Exercise, obviously support groups, social activities, mindfulness, yoga, take charge. Anything you do is always going to be a good thing, as long as you're sort of empowering yourself to make the decisions for yourself. Because like I said, so much of the cancer treatment was beyond your control. That's what I tell my patients. Take time to care for yourself. Personal reflection is the most important thing. And as I get older and older, that I understand the power of this and how important it is, and all the relationships and all that, not just for you, but how you navigate the people around you, and how you communicate about your emotions. It is so, so important. Keeping a journal is incredibly important. Blogging and developing hobbies. I mean, those are sort of key ways in which you could sort of start untangle the complexities of a cancer journey. But by no means do it by yourself. Obviously this is a remarkable organization here, but there are online organizations, whether it's the American Cancer Society or Blood Cancer United for patients with hematologic cancers, or the American Society of Clinical Oncology. There are a number of resources and tools that are at your disposal, and it's only getting more and more sophisticated and more nuanced and more survivor friendly, because this concept of survivorship is emerging as one of the most pivotal public health issues that is facing this country. When we're talking about 20 to 25 million cancer survivors in the United States in the coming years, that's a massive demographic. So what can you do to start the process? Keep a personal health record. These are the questions to ask, and some of this may or may not be relevant, but I always tell my patients, as you're starting to near the end of your journey of your cancer treatment, who will be leading my medical care after I finish my treatment? Is it going to be my primary care doctor? Is it going to be you? Is there a specialized survivorship program? Some places have them, others don't. Ask the provider who usually provides survivorship care. Is there such a thing as survivorship care? If not, are there hospitals and programs where that is a part of it? Are there survivorship clinics? Are there centers of excellence and other places that you would recommend to help navigate this next journey? How often should I do my follow-ups with you? And when you're following me up, are you only following up for the cancer recurrence, or are you also following up for the potential side effects that may come up later on? So that's a question to ask. What tests will I need? And then this is the most important thing. I fundamentally believe that if you go through a cancer treatment, you should have basic access to the cancer treatment that you receive. Basic. And it doesn't need to be super complicated. American Society of Clinical Oncology has sort of some of the basic points that are quoted. The reason why I put this here, not for you all to read it, but ASCO, the American Society of Clinical Oncology, almost every one of the oncologists out there is probably part of that organization. And they essentially recommend that each cancer patient should have a treatment summary that talks about when they were diagnosed, what was the cancer that they had, what stage was it, what treatments did they have. Was it chemo, radiation, surgery, all of the above, immunotherapy? And ideally, what doses of medicines that they receive, because sometimes the dose matters. Like I told you about that patient with the heart failure. The reason why she developed heart failure is because she received high doses of certain chemotherapy that's very effective, but rarely can cause that problem as well too. So it's important to have that information and at your disposal. It typically doesn't need to be any more.
Question, City of Hope, this care plan, do they have someone that will do it for you, or you're going to each specialist getting that?
Yeah. So we are now generating these. So one of the beautiful things about having electronic medical records. So it takes a while to develop and establish a culture of electronic medical records because it's so easy just to write your notes and stuff. But one of the beauties about electronic medical records is you can pull that information on the back end. So you should be able to generate a treatment summary for all patients.
But from each individual specialist, right?
No, it should have a composite for everything that you want. Yeah, but if what I would say, they've been slow to roll it out, but now if you ask your primary or your regular doctor, they should be able to. It's just like a click of a button.
What is it called?
Treatment summary. Just call it a treatment summary. Yeah. If not, you can just email me, and then I'll make sure that the right person gets disciplined.
Those records don't go to City of Hope, or CLA does, and so I'm always having to forward those separately, so that wouldn't be included in something.
Yeah, at this point, unfortunately, not because we don't want to. There's been increasing virtual walls that are created between health systems, and it's been driven by privacy concerns and sort of leaking of information concerns, et cetera. But as a researcher, I think that's a travesty, because what happens in one medical center, I want to know about so that I can contextualize what's happening in this center as well too. So I can talk about the full journey of the patient. I do fundamentally believe that there will be a time when there's going to be sharing of information across health centers. But I think we don't have to wait until then. So there will be probably in the next year or two, a growing web-based, cloud-based portals, patient portals, where you can sign up and actually give permission to that company to then access those records and put them in the portal for you. So where you have all of your records in one place. One of the big problems that happened with Joe Biden's son, for example, was he was diagnosed, in the one who had a brain tumor into the vote. He was diagnosed at one center, and then when they went to another center, they didn't have access to the medical records, and it was really hard for them to navigate a lot of this stuff. And so they created this mechanism where patients could own their records wherever they are, and ultimately upload it up to the cloud with a secure platform. So that the infrastructure is there, and I think it's going to be much more commercially available. Yeah.
I just realized this year that the government reached out, that my entire family growing up, because I was so young, I didn't realize we were exposed to nuclear radiation, and they identified 21 cancers that were related to that exposure. And my dad actually died young from it. Other than the normal things you do to prevent further cancer, is there anything that's happening in the world now that's addressing that issue? It was where I grew up in.
Yeah, I think that is probably going to be in the sort of in the realm of like the CDC, because that's they'll be tracking for certain cancers and certain signals based on. Oh,
No, why.
So I'm almost done here, and I'll be happy to take some questions. But like I said, just it's important for all patients to learn about the treatments that they receive, that there is some element of survivorship focused care that's integrated. I'm not saying that you need to go see a survivorship expert monthly, but there needs to be some element of collaboration between the primary team, primary family practice doctor, or internal medicine doctor, and the oncology team. The long-term follow-up plan, I talk about healthy choices. But ultimately, what I tell all patients is that doctors come and go, health systems come and go. The only person that's going to be constant is you. The only person who's going to be advocating for your health and for your well-being is you. So the more you can learn about your cancer, the more you can learn about the potential side effects, the more you can learn about the potential things that need to be monitored based on the unique treatments and exposures, the better you're going to be. some things are avoidable, some things are not. But you want to make sure that the ones that are avoidable, that you're on top of. And it's basic stuff. Yeah, you would be surprised how important physical activity and exercise is to the broader symptom cluster that many of our patients have. And we're not talking about running marathons. We're talking about integrating some level of physical activity, 50 minutes 3 times a week, 30 minutes 5 times a week, light walking, jogging, some resistance because you do lose muscle as you get older. Is so important. And then compliance with your medication, getting better control of your blood pressure, cholesterol, thyroid whatever you are on, good compliance and good control of those conditions could really make a dramatic difference. So this is a celebration of life that we have at City of Hope once a year. There's a reunion of all the cancer survivors who've undergone bone marrow transplantation. Now this is from the 41st annual, but last week we celebrated the 50th anniversary of the bone marrow transplant program. And it really is life affirming on many levels. If any of you have any questions or concerns about anything I brought up or anything that sort of piques your interest or want more information, this is my email address. I think it's being recorded. Yeah, so I have a couple of minutes. I have to run, unfortunately, I have to run clinic this afternoon. But I wanted to. When Doug called and said, you mind coming back? And I said, I was first honored that you would ask me back, but second, I said, of course, it's a great pleasure and honor. So somebody had.
I do all my stuff through Cedar Primary program, and I have a genetic cancer, so I have a twofold sector. And the first is, how these kind of works out. All the things that you're talking about, like, I went to my primary and I have some difficulty breathing, getting back to exercising now, work, and, I feel like my pleasure is all the different things, and I tended to play it down, like, I haven't been exercising that much, and I'm just getting there.
Yeah.
And there was not a conversation about, that could actually be related to treatment, but just parsing out, like, what is actually related to treatment and how you have this rotation with your primary versus like, I just gotta be 56, so I'm gonna menopause, they could be anything.
Right.
But
Yeah.
it's to kind of help guide that a bit better.
Yeah, you first need to start with understanding that anything that you communicate about is better than not communicating about it. So the more open you are about what your symptoms are. Worst, best case they can say is nothing, don't worry about it, it's not related, or it doesn't sound too serious. Okay, great. But at least you've communicated that. The second thing I would say is that make sure that you know who your audience is. So you have to understand who you're talking to. So if someone, doesn't have the full awareness of what the potential risks are based on the treatment that you receive, probably need to find someone who does, who has taken care of people who are long-term survivors, who has read about the different studies and different side effects and different things that they should be anticipating. So you will ideally want someone who isn't just really good at treating the cancer, but you also need to partner up or find somebody, if it's not that person, who really understands what the survivorship journey is and what they should be looking for. And then they can tease it out for you. You shouldn't have to do it yourself. You should just have to communicate. You should just share what you're feeling. That's all. You're not a clinician. You're not supposed to go through all the different things that it can be. And heaven forbid you shouldn't be going on Google and putting a shortness of breath. Chat GPT or whatever it is.
Specific survivorship type clinics, or I'm still seeing my medical oncologist.
Yeah.
And she's medication and monitoring those specific things, but
Yeah,
my primary doctor.
It's not as sophisticated as like a formal structured clinic. They're not as sophisticated. So they tend to be bundled. And there's no. The simple answer to your question is there are broad survivorship clinics that base all cancer, regardless of what the answer is no. Some places have, let's say, a really good breast cancer survivorship program. We have a really solid childhood, adolescent, young adult cancer survivorship program. Other places have a strong prostate cancer. So it really depends on places. So from a structure perspective, we're not there yet. But I would say that where we are, the fact that we're even talking about this today, we wouldn't even, there weren't really like survivorship slide decks and stuff 5-10 years ago. So I'm optimistic that there will.
So in your medical oncologist, they come your survivorship line doctor, or are there some, things you transition to a different medical oncologist?
It depends on the site. It depends on the facility. Like I said, for the childhood, adolescent, young adult one, for example, I will take care of lymphoma patients. But I will also take care of like a 50-year-old survivor of lymphoma who was like 12. So that's just the uniqueness. Other places, it's a pure handoff, the survivorship program, where you have advanced practice providers like nurse practitioners who are exclusively focusing on survivorship, not necessarily on a primary care. So no, it depends on the person.
We don't know this based on your specialty, but one of the things with some of the cancers is that they no longer give you scans.
Yeah.
To
Yeah.
track
Yeah.
recurrence. And so now one of the things that they're doing are things like the Signatera blood test,
Yeah.
circulating to
Yeah.
a test and so forth. But now I've been hearing in the news that they've been testing other blood tests that track lots of different cancers, not
Right.
just one, not just yours. And so where are you at recommending that? I know insurance isn't covering
That's
that, but apparently it's on track to, so.
Yeah, I think the big results coming up that are going to be reported in June about what they call these MSET tests, which is multi-cancer something early detection panels, which include multiple cancers that they're picking up on a peripheral blood tests. So I think once those papers and their scientific those studies get published and they're peer reviewed, I think they're going to be much more available to the broader community. Probably in the next couple of years. Yeah. And the scans, I would just say is I'm not a big fan of scans. The only time I think scans are important is if doing a scan is going to change your treatment or is going to cause is going to minimize like sort of the intensity of what you're actually going to do because the number of there's the radiation factor that you don't want to keep adding more radiation to people. And then B, the number of times I've seen it not only creates additional diagnostic workups and tests that inevitably end up being negative and cause anxiety and costs and everything else. But the relative utility of a lot of these scans and stuff we're starting to recognize it's low. For some cancers, they're important. And for a certain period of time, it's important. But for others, we're starting to appreciate why it's not. It's not just the cost, but it's also, like I said, the physical damage that the scans can themselves be doing.
My issue is always, yes, the data, the stats tell you one thing.
Yeah.
But then you have those personal stories like
Yeah.
my father-in-law, just because the Rotary Club was doing some health festival and then he got some deal for $25 for a CT scan and found lung cancer really early.
That's right.
You know what I mean? So it's like, there's always that conflict. But what the general data tells you and then an individual case.
I think you said it well. Unfortunately, you have to stick to the data because you only hear about the positive ones. You don't hear about all the ones where they got this test and then they went and got the biopsy and the biopsy went wrong. All of a sudden they got in the hospital for 5 days because they had a leaking whatever. And you don't hear about any of those things. You just hear about the positive ones. So I'm not saying anything about it's
How do referrals get made? Like when I was in the hospital with Huntington, twice a hematologist from City of Hope came to see me. I really appreciated
Yeah.
it, but then I realized, how did anybody know to call me?
I mean,
Is it just doctor to doctor?
yeah, we don't go in and like jump in and like randomly start seeing patients.
It's personal relationship.
Yeah. Some relationship where there was a skill set that maybe somebody was
That's
like.
why I'm writing in my chart. I mean, I have I can see everything I said, everything they said.
I'm one more.
We need to scan and then you're going to recommend that.
Which one?
I think it's covered. Yeah.
Full body scan.
Oh, yeah.
That's the next thing.
Yeah, I'm not a big fan of like full body scans, you know. I really am not. I mean, there are some very rare situations where it's important, like a genetic predisposition for certain types of cancers, like neurofibromatosis and other things that, you know, less than 2% of the population have. But in general, just being a cancer survivor doesn't get that there's no advantage of doing additional scans, other things. Um, yeah, I always say, you know, does getting a scan, will it change the treatment plan? Will it change the staging? Will it change how aggressively we were going to treat you? More often than not, if it doesn't, then all it's going to do is it's going to lead you down this path of workup and worry and anxiety without necessarily changing the treatment or even the prognosis. That's what really what it is. If early detection changes prognosis, then yeah, they'll continue doing it. Anyway, thank you so much for your time. Everyone took a chair. Oh, yeah, traffic on the way back. I'm good.
Thank you so much. I'm gonna give it to you. Never be. I'm gonna put it at the top. Even though yes. You know, it must have been to get to the actor. Like, yeah. And so I got it. And I know it was going to get certain. I'm like, my parents, that was, you know. Here I went. And I was from my daughter. That's what it's so kind of so fascinating. Right. So I thought it's like the yeah, but that's right. Like I keep seeing the fantastic. I think it's just good. It was good. And like I thought that's the hard thing, right? She goes.